It's time for the Kim Hammer Show, where you'll learn how your state government affects you, your family, and community. Here's Kim Hammer.
Good Saturday afternoon. Hope you're having a great Saturday and enjoying your weekend and just enjoying family time or whatever else you're doing. I'm going to dispense with all the pleasantries and get right into the subject matter because we've got a pretty full show today. I've got Pat Davis with the who's the health plan man. You've heard him speak to Dave on his show many occasions, but I've asked Pat to come on because he's got a unique approach to dealing with health insurance, and we're in the middle of the debate about health insurance for teachers and for state employees, and we actually have hired consultants that are coming in to give us some guidance. And having listened to Pat on Dave's show, just wanted to have a conversation about the way in which we provide insurance to people and the opportunities that are out there to see if it's part of the formula that we ought to actually be looking at. And then on the second part of the show today, I've got Dr. Dillaha from the Department of Health on. We are going to talk about the vaccinations. We're going to talk about the current COVID rate and have a discussion around that, with that being kind of the focus of attention in the state right now, including masking and some of the issues around that. So hang on to the second half of the show. I'll have Dr. Dillaha. But right now we're going to talk to Pat Davis, who is with the who is the health plan man, as you are known.
Yourhealthplanman.com.
Yourhealthplanman.com. I want to get it right. So, all right, so let's get right into it. I want to, first of all, just for credibility purposes, what is your history in working in the insurance field, especially with healthcare, and give me some credibility factors about you that you could be on the Kim Hammer Show today.
Okay, thanks. I appreciate being on here today. I've been in the insurance business in general for about 18 years now. As far as health, part of that, actually during that whole time, I've been doing some health stuff off and on. But what I've been doing in the last about 3 years is a whole different approach to health insurance, which really begs for a different approach to health care in general. And one of the things you hear over and over from even from our politicians, they'll say health care and health insurance in the same breath and use them interchangeably, and they're not the same. Health insurance is definitely not health care, but they make it sound like it is. And I think the philosophy, especially of this administration, more than any I've ever seen, is that we have to make sure that no matter how expensive health care gets, no matter how ridiculously off the charts the prices go, we've got to have insurance that's going to be there to cover it. And so many of us have been saying for a long time, ultimately what's going to end up happening is the government's going to have a high risk pool that people are going to go to. And, more and more people are going to want to keep some kind of private insurance because, let's face it, especially most of your listeners, I'm sure, don't want the government's hooks, in their health care, if at all possible. And so what we do is kind of just the opposite of that. We work with things that we try to use to help drive costs down. So a good example, I just heard the other day of a guy that he started a program called healthcarebluebook.com. It's kind of like your, Kelly Blue Book for cars or whatever. You can, and another one is like MD, like medical doctor, mdsave.com. You can go and you can find out how much stuff really should cost for healthcare. But the guy that started the Healthcare Blue Book his son had a sports accident, tore his Achilles tendon actually, and he had to have it stretched, and he called, and the first place he called quoted him $37,000, but they said real matter-of-factly, but all you got to do is pay $5,000 because that's your deductible, no worries. Well, they didn't realize they were talking to a guy who had an MD from Duke University. So he said a doctorate degree. So he said, I think I'll get another opinion. I'll get another price or whatever. Within minutes, he gets a call back. Oh, it's only going to be $15,000, but you still only have to pay $5,000. He said, okay, I'm going to look around. So he shopped, and he called a friend of his, and his friend said, this is a clinic I would recommend. They have one of the best reputations. $1,500, 25 times less than his quote that he got from that clinic. from that surgery center. And so this goes on all the time. I know a guy, and maybe someday we can work something out and we can have him call in or whatever, but he's one of the heads of the largest surgery centers in America. And in 23 years, they've had 3 changes in their pricing. 3 times in 23 years. And here's the kicker. In all 3 cases, they lowered their prices.
So what is it that's driving it as far as the price difference? Is it the barriers that are prohibiting people from actually being able to negotiate with their healthcare provider because of ACA, or what is it that's the firewall that's keeping people from being able to have that interaction?
Yeah, excellent question. I would say it's a combination of different things, but the philosophy of the Biden administration is we're going to continue to put out every kind of fire we can. The philosophy should be, let's take away the matches. Let's find the places where the fires are starting and get rid of them. So what happens is you have a big name company. I don't care which one. You can name it. I won't, but you can name any big name company that people that are listening have for insurance. And they're at the heart of the problem, in my opinion, because they allow this stuff to go on.
But why do they allow it to go on?
I think it's a lot of things. I think one is it's greed, you know?
Now, you had experience before you started approaching providing coverage, or what's the right word? You said us politicians get it wrong. Not health insurance necessarily, but health care.
Right.
Before you started taking this approach, did you work for one of the big boys, or?
I have a little bit. I did a little bit after the ACA came into place. And understand, the only reason I did is because I kind of had to. I had people that were coming to me and they wanted to get insurance, and you know, it was almost like I don't know what you want to call it, the lesser of evils or whatever, but and now the same thing. I mean, I can give people counsel, and I do, on Christian share plans. And that's one thing I tell people all the time. You listen to a radio ad, you have one company who's asking you to get their prices or do whatever else. I can tell them all the ones that are out there if they want. I can tell them about a plan with Ambetter, Blue Cross, United Healthcare, the different plans that are in the marketplace, and I can offer those plans too. But the way we keep our plans the way we do, and the plans that I prefer to use, is I go in, and because I'm independent, I can write for any company I want out there. I want to try and find plans that don't get sucked up in that system, to where we use what we call a fair price system, like Healthcare Blue Book will show you what a good price is if you have, for example, a 4-night stay in a hospital with a pulmonary embolism like I did in 2019, almost died. I was in the hospital 4 nights. I could have gone out of there and paid $7, $10, however many $1,000 with my deductible, right, and my out-of-pocket for that year. But I'd left behind my Blue Cross plan at that point in time, and I'm on my private plan with my company. And not only did I get my bill paid in full with no money out of pocket, I had almost $3,000 check that I got sent from the company, because I was smart with my health care, and I didn't let the health care, provider be the one that dictated, or the insurance company.
Okay, so I'm a provider. I'm a hospital. I'm a surgery clinic. I'm a doctor's office. I've got to have the built-in cost to cover my overhead. The prices that would be covered normally, to your situation where you said, all I got to do is pay the $5,000 deductible and the rest, how much of that is survival for the facilities and the providers that they have to build in that much additional cost in order to keep the lights on? So when I pull up and I need medical services, I know they're going to be there.
That's a great question.
We only ask great questions on the Kim Air Show, by the way.
That sounds good.
Yeah, listen to the other stations if you want the other ones. But anyway, go ahead.
So hopefully I could give some good answers.
There you go.
For sure. And this is the
and
answer,
by the way,
right?
By the way, we did not rehearse this conversation to the depth that we're going now. So this is really just sit down and conversation. All right, go ahead.
Here's my notes.
There you go. All right, go ahead.
Yeah. This is in my heart. And it's a big passion of mine. And I'll throw a few books I recommend people read. Read The Price We Pay by Marty McCary. I mean, you'll hear that name, Marty McCary, if you listen to Fox or if you listen to Newsmax. They almost throw it around like water anymore. Marty's, tremendous surgeon from Johns Hopkins in Baltimore. And what's incredible you'll read stuff in his book about a police officer in Carlsbad, New Mexico, who has to go and get a CT scan done, and they didn't put the dye in. So he had to get another CT scan, and they billed him for both CT scans, $26,000. And Marty said you could go to Johns Hopkins, the Johns Hopkins University, and pay $500 cash for a CT scan.
But are they underwritten by taxpayer dollars to where they can afford to do that, whereas a private hospital could not afford to do that?
Most of the most expensive hospitals in the United States, almost bar none, are not-for-profit hospitals. That's a fact. That's one of the things that he details in there. And he's like, okay, I hear all these arguments about why our prices have to keep going up, but it just doesn't make sense. So like the guy I was telling you about that has a surgery center, he'll say, people come up to him all the time and say, how come your prices are so high? And he goes, the answer really isn't that. The question should be rephrased. How come yours are so? I mean, why are your prices so low? The answer should be, why are yours so high?
Right, because if you got side-by-side facilities, the one that you're illustrating, and those doctors are getting paid the same, they got to make the mortgage payment, their facility upkeeps, all that are the same, and then you got a facility sitting beside them that is catering, say, to the traditional approach to dealing with healthcare costs,
right?
And they're different. That begs the question: what's the difference in the models? That one has to charge this much and the other one doesn't have to charge as much.
Absolutely. So a good example, the one I was telling you, the surgery center, there's a hospital around the corner from it. And so the surgeons work in both. So they know the pricing and stuff happens. It's 75 cents for a steroid injection, and they bill the insurance company $350. I mean, that's just, they can say what they want. To me, that's fraud. It's for sure abuse.
That's like the $200 aspirin.
Yeah, $200 aspirin. I saw a video the other day. In fact, it was with Marty McCary. I was watching on my LinkedIn, I'm connection with him. And this lady called in. She goes, hey, it was on a video. I paid $100 a night for the tray that they brought my meds to me when I was on the hospital. $100 a night for what, a 25-cent, 50-cent tray?
Is that to cover the cost of the facility? And I'm asking you a judgment call. Or is that padded expense to cover the cost of the facility? Or is that other motives? Or is it just, this is the way we've always done business?
Sure.
Don't break the model.
I think it's a combination of several of those different things. I think the heart of the whole thing is that they don't have to do it. They keep saying they have to do it because if they don't, they're not going to be able to, their prices are going to be in line and they're not going to be competitive or whatever else it might be. When you read Marty's book, it's such an eye-opener, The Price We Pay. It's such an eye-opener because Marty said some of the most incredibly expensive procedures and whatever and care done in the United States has become some of the most shoddy and the worst level of care. Because people think, man, if I pay enough money, I should get great health care. I should get tremendous surgery. I should get this. I should get this. But the biggest thing they find over and over and over and over is the way they judge the success in the healthcare industry. It's not based on whether or not this should happen. It's whether or not the person doesn't have so much pain after the event, or how are they followed up with, or whatever. So it's all based on factors that are really easy for the hospital, for whoever, to be able to monitor without going in deep and finding out the real thing, and that is, was that even necessary at all? So some of the least effective drugs in America are some of the most prescribed drugs in America. Some of the least needed surgeries happen more than any other. A good example, and I hate to have to even say it, the number of C-sections that are done with women that are not necessary. He talks about in his book, there's even a doctor they exposed called Dr. Friday, that he was going to get his number of surgeries done before a certain time so he could go play golf. And that might be an extreme, but somewhere between those that are really fighting against that and those that are doing that are lots of, people in the middle that fall into those same things. And they do it because it's the thing to do. That's where I was addressing the last thing that you said. It's just accepted. It's the way to go. You pay $10,000 cash for a pacemaker, or do you have it billed to your insurance for $100,000? So what I tell people is, look, you can complain about your insurance all you want, but if that's what you have is a company that's a big name company and that's what they do, then you have to admit down inside, you're also part of the problem.
But those big name insurance companies are then working on those providers that are part of their network that, yes, it's $15,000 above the cost. Are they not pounding on those providers to negotiate what they actually pay the providers for the true delivery of service? Are you somewhat taking through what you're proposing or what your model is, removing the middleman so that's a direct connection between the payer and the provider and removing the middleman?
Yeah, absolutely.
Which is what Shared Care Ministries and other, because I've had them on the program too.
Right.
Is it the similar model or what's the difference?
Well, the difference is we are actual insurance, okay, which is really important for people who own a business, okay? Self-employed people cannot write off premiums for a share plan. It has to be some kind of health insurance. And the ones that I do are that way. They're just not your typical major medical plan where you put your money on the table until they say, okay, you've forked out enough dollars, now we're going to pay the rest. Ours works just the opposite. Ours, the insurance company puts its money on the table first. And then if there's money left over from that after the bill is paid and whatever else, that goes to you. So that's why I got the check after I went to the hospital for 4 nights. Whereas if I would have kept my plan I had before with the big name company, I would have been out of pocket a lot, several $1,000s.
I asked the Shared Care Ministry folks when I had them on, how do you break the fear factor of people leaving what they have known all their life as the traditional route to take care of their needs and transition to what you're talking about?
Yeah. I think it's a funny answer, but it's the Wizard of Oz.
Pull back the curtain.
Pull back the curtain. And who pulled back the curtain? A little dog, little Toto, pulled back the curtain and exposed the fraud. That's what I feel we do with companies that are trying to work off of a true price model and a fair price model. Then people get brought into alignment and clinics and hospitals, whatever, get put into alignment on what should be fair pricing. So here's a good example. I am, because of my pulmonary embolism, right, a couple of years ago, I take Eliquis, a blood thinner. It cost me so much money to get my blood thinner here in the U.S. So my doctor at St. Vincent said, just go get it from a Canadian pharmacy. And you know where I actually get it? From Turkey. They ship it to New York, they test it, they send it to my home, and it costs me about $200 and some for a 90-day supply versus thousands of what it would cost me in the U.S. And that's sad. This previous administration was moving in that direction with that favored nation thing. I couldn't wait.
You're talking about Trump administration.
Yes. The favored nation thing was going to make that happen. So any price you could find anywhere else in the world, you would be able to get your med in America for that. Well, obviously that's not on the table, and that's made a big difference. So now, not only is that true, but people who are taking insulin, I've heard more horror stories than I can count of people that their insulin prices have been driven out of sight. And yet Washington, they're saying, oh, it's all the fault of whatever. No, it's their fault because they could get a bill passed that would start going after that junk. And it's sad. It really is.
You used the term fraud a while ago. That's kind of a strong term in the context. Is it fraud or is it just a savvy business model that's never been challenged before?
It has to be the latter, because if it was fraud, it would probably end up somewhere eventually being tested in court. But to us, it's fraud. To us, it's at least abuse and a lot of waste that goes on. It's driven into our heads in the insurance business is you've got to understand fraud, waste, and abuse, and you've got to know those terms. Well, I know that it's not fraud. But when you talk to the average American, to them, they're going to say, yeah, that's fraud. it's for sure high level of abuse. And as one of my clients said, that's legal theft is what that is. That's a good word, because it is legal, like you said. And whether it's because it hasn't been challenged or because there's so many lobbyists that are fighting against those kind of things and keep that from happening, I don't know, Kim. I don't know what the answer is on that. All I know is if a person's listening to me and they don't get paid to go to the doctor, they got nothing to lose by calling me. That's it. Okay, if I give them my number real quick and my website, is that all right?
I don't care. Go ahead.
Yeah, it's yourhealthplanman.com, and my name is Pat Davis. My number is 501-605-6935, and I have a thing going right now with, the answer and the fish right here. You text me your name first and last and the number 25, and I'll give you a quote, and then you can get a free gift card, $25 gift card. I'm doing that through the end of July. So you definitely want to text me and do that. And there are a few restrictions. Okay, there's a few restrictions that do apply. And one of them is you can't be Medicare or Medicaid eligible, and it's for 64 and younger. So that's one of the things we started doing. But we have so many cool things that are happening right now with my business. I have several, like 36 agents now that I've brought on in different states. And we're all passionate, and we all do the same thing. We save people money. 30 to 50% is not uncommon. We're starting to do stuff with government, entities. We're starting to show people ways they can save money. Businesses, especially businesses that are like 40 employees and less. We've got some just incredible options for people like that. But the biggest thing is we're helping people take control of their health care. So when people ask me what I do, I never say I sell health insurance. What I do is I help people get in control of their health care and take it out of the hands of the insurance companies and providers.
But you're appealing to a population that is responsible for their actions and invested in their own outcomes. That's a percentage of the population that's covered by traditional insurance. You have a portion of that population also that don't really care. They don't mind going to the ER umpteen hundred times a month because they don't, it doesn't cost them anymore. What do you do with the leftover population that aren't attracted to the mindset that you're talking about, and they're left to the traditional plans?
Well, I think if they have a traditional plan, they have at least some interest, or it's forced on them, one or the other. I'm not sure what it would be. But those people, we have plans. Our rates are so good that we have people that fit those, demographics too. So the only people really that aren't going to have insurance are people just don't want it. And we knew immediately when Obamacare was proposed and everything else, we knew it was going to be an issue because younger people are not going to go out and get insurance unless they're forced to. And that's what they had to do. And I think that makes it pretty clear how bad a policy is if you have to force people into it, right? I mean, that's really what happened. And so the same, young people that say, hey, I don't want insurance at all, but I'm willing to have a plan that I'm going to get paid to go to the doctor and do the kind of things you're describing. I have a lot of clients that are in their 20s, a whole lot, and a tremendous number of couples in their 30s, 40s, 50s, of course, even 60s, but for sure in their 20s and 30s. We have a lot. Because a lot of them are starting to understand the value of protecting themselves.
Do you, your plans meet the definition of ACA? Until we get rid of ACA, your plans conform to the requirements of ACA?
They do not.
Okay.
They do not. That's why I work in conjunction with ACA plans and provide benefits that go alongside of it and can actually lower the premiums of an ACA plan by covering the things that the ACA plan doesn't. So kind of use this example. If you go out on a date, you're on a blind date, of course you're married, so if
I
you
won't be dating except for
you're
my
going to
wife,
get killed,
anyway,
just like me. But hypothetically, you're on a blind date and you show up and she's got the worst attitude you've ever seen. It is ugly. Right? Then she orders all the most expensive stuff on the menu. Now you've got ugly and you've got expensive. There's not going to be another date. But I've just described our healthcare system. So even though they're making it more affordable to people. It's still the same ugly insurance. It's really ugly. It's got deductibles that are going higher and higher and higher. So what we do is we help people to get, and it sounds kind of like I'm contradicting myself, but to get a higher deductible, and then we put a plan in place that gets rid of that deductible and covers the copays when they go to the doctor or whatever it might be, up to half on those. But I started asking people, would you rather pay $5,000 after going to the hospital, or $500, or even nothing? Dumb question, right? But the reality is, way we build plans, we can do that. So you could take thousands of people and lower their health premiums and add in another plan layer, and all of a sudden you've got basically about the same amount of premium per month, but way better benefits, and your people are happy because they don't have money out of their pockets.
Got to take a break here on the Kim Hammer Show. I've got Pat Davis with get it right here, look at my pen, yourhealthplanman.com. We'll be back after this. Dr. Dillaha will be joining us in the second half. I'm going to hold Pat over. Come back to the Kim Hammer Show. Welcome back to the Kim Hammer Show here on a Saturday afternoon. Thank you for joining me. I've got right now, I have Pat Davis with yourhealthplanman.com. I'm going to put him on hold for a minute. He's going to sit here because we're being joined by Dr. Dillaha with the Arkansas Department of Health, and we're going to talk about vaccines and about the virus and just a few issues that are kind of in the news and hot topic right now. And so, Dr. Dillaha, thank you for taking time out of your very busy schedule to join me here on the Kim Hammer Show.
Well, I'm happy to be with your show today.
All right. You are a returning guest. You've been on several times before, back during the first wave of the COVID, and so I appreciate you taking time out. I just wanted to visit with you a minute, give you a platform. First thing I wanted to do is just ask you about the current numbers as of today that we're looking at as far as those that are affected in the state, and just give us a rundown on the numbers if you got them handy.
Well, I'm telling you that we've had, as of the end of the week, 1,860 new cases, 1,860 new cases, and that we have also had a large number of vaccinations that have occurred, which has been wonderful. We've had about 14,000 vaccinations that were reported on Friday that had occurred the day before. So that is a ray of hope for me.
Very good. Now, you mentioned 1,860. Is that for the week, or was that just through Friday, or what time frame was that 1,860?
So actually, those were the numbers that we had that were reported on Thursday, and I have not yet seen the numbers for Friday. Just one moment, and I can tell you what they are.
Okay.
So Friday, we had 1,987 cases. So both very high numbers 2 days in a row.
Okay. And I'm just, I know that UAMS has made some projections, and based on historic experiences, last year when the COVID outbreak was taking place, the numbers that we're seeing today, how do they track with the numbers that we were seeing when the first round of COVID came through the state? Do you see that the model is the same? Are we a little bit lower, a little bit higher, or and we didn't rehearse this, so I'm asking you questions you didn't know I was going to ask, but do you know?
Yeah. So I don't know how they track the numbers. I can tell you, right now we have 13,784 active cases. That means the people who are currently infectious should be in isolation right now. We know that's the tip of the iceberg because a lot of people don't get tested because they have mild symptoms, and some people don't develop symptoms at all but could potentially spread COVID-19. This is twice as high as we had at this time last summer in terms of active cases. So it's very likely we will see high levels of spread in our community for some time, because now what's spreading is the Delta variant, and it is much more infectious than what was spreading last summer.
Let me ask you about on the testing, because this is a personal experience I had with a friend. She thought she had COVID. She went, she got the rapid test. Rapid test said positive. Next day she went, she got the PCR test. It came back and said negative. Does that rapid test that she had on Sunday afternoon count in those numbers that you're giving out, or are PCR or are the rapid tests even considered in the numbers?
So we do consider the rapid tests. Usually when people have symptoms and they have a positive rapid test, that's pretty trustworthy. But sometimes people who don't have symptoms get the rapid test and it's not so trustworthy. So a PCR is much better. So if she wasn't having symptoms, then I would be more likely to trust the PCR.
Okay. And like the 1,987 that is recorded as of Friday, is that a mixture of the rapid test and the PCR, or would that just be the PCR test numbers? Or
It's a mixture. So
okay.
It's both situations.
Okay. And let's talk about the vaccinations for a minute. 12,000 is what you said. Do you think that with the recent events and just the concern level that is being raised, that is motivating people that otherwise would not have gotten vaccinated to now they're seeking vaccination?
So I must have misspoke. I meant to say 14,000.
You may have said it and I wrote it down wrong.
Yeah. But I do believe that people are sensing a more urgency in the current situation. Last year when we had the high number of cases around the state, it didn't affect everyone. It was mostly certain communities where they had outbreaks and spread, but some communities weren't very affected. And now with this variant that's spreading, it's going everywhere. And it's finding pockets of people who are not immune and spreading. So I think it's becoming more real to people. They're having more direct experience with it, especially young people, because many young people at this point in time are going in the hospital, whereas last year there weren't so many people who were in the young adult age groups that were being hospitalized.
The 12 and under vaccine, or the vaccine for 12 and under, last report I read, and I could be wrong on this, they're hoping within 2 months to have that vaccine out. Do you have any current information as to the timing of when the vaccine would be available and approved for 12 and under?
Yeah, so right now the clinical studies are going for its ages 5 through 11. 12 and older is already authorized. And so this study that they're doing for this age group, the website for Pfizer and the press releases I have seen talk about it being ready in September or October. So hopefully if it goes well and the data look good, then that age group will be authorized. And that will go a long way toward keeping kids out of the hospital as well as keeping our schools open.
Okay. The conversation around the mask, of course, you're in tune with what's going on. The legislature passed a bill that prohibited schools, government entities from being able to mandate the usage of masks. And this is this is just a little bit of a personal opinion, depending on which, CDC report you read, depends on what they say about the mask. And I think that's contributed to some of the confusion. But the most recent statement I heard was that if you have been vaccinated, you're not required or recommended to even have to wear the mask. The mask is for the benefit of those that have not yet been vaccinated. The usage of the mask, as far as, is it necessary for those who have been vaccinated to wear it in order to keep it from being spread to those who have not yet been vaccinated? Speak to that and just give us your professional position on that matter, please.
Sure. So CDC has said that people who are vaccinated don't need to wear a mask. And for the most part, masks are to keep people from spreading it. But people may wish to wear a mask, and they actually encourage it for people who are at high risk for severe disease, even if they are fully vaccinated. We know that maybe 5 to 10% or more of people who are fully vaccinated could still develop illness, especially if they have a weakened immune system where they might not respond as robustly to the vaccine. So people in that situation are encouraged to wear masks to protect themselves. And they would probably need to wear something like a KN95 mask, which works better to protect the wearer than some of the cloth masks. Many of the masks are designed to prevent spread, but people who are fully vaccinated may wish to wear masks to prevent themselves from being infected by people who are unvaccinated and not wearing masks.
With the vaccinations, what percentage of, where are we today as far as the percentage of the people that are vaccinated in the state, their first vaccination and their second? We got a population of just around 3 million people. What are the numbers in relation to our total population as a state?
So let me see if I can actually pull it up and give you the most recent information. The Arkansas Department of Health maintains a website with a dashboard, and so people can go on board and get that dashboard and look at it. And it, hold on one second, I'll pull it up. And this dashboard is updated daily. So it shows the age groups that are authorized to get the vaccine, 12 and older. So at this point in time, the percent of people who are 12 and older in Arkansas who are fully vaccinated is 40.5%. And so that would be about 1,035,479 people. That's what we have listed. And then those people who are partially vaccinated are 10.3%. And so that would be 262,608 people. So those people are on their way to getting fully vaccinated, but they're not fully vaccinated yet.
The 1 million number are those that are fully vaccinated. Is that what you said?
Yes,
that is correct.
Okay. And are you finding throughout the state that the pockets where people are vaccinated, are there isolated pockets where people just aren't vaccinated, or is that number spread pretty equally across the state? I'm wondering if you got regions where it shows that people are not as vaccinated as other regions in the state.
Well, if you look at the map, which goes on our website, you see that people in Southwest Arkansas have lower rates of vaccination, but that's a little bit artificial because many of them went to Texas and got vaccinated, but Texas is, by their law, cannot share the data with us. So it's hard for us to get data about people who reside in Arkansas that got vaccinated in Texas. But there are a few counties that have low vaccination rates. And if you click on any county of interest on our website, you can find it. one county that is would be of interest would be, say, Newton County has a low percentage, and that is 23.9% of people who are fully vaccinated. But then there are some counties like Chico County has 38% fully vaccinated, and I'm looking to see if I can pull the number. Deshay County has 42% people vaccinated. So it varies from county to county, and it's not necessarily urban or rural. It just depends on the various counties.
Okay. Give me the website, if you would, so I'll put that up on my website page and people will have it. What's the website that people can go and track those numbers?
It's www.healthy.arkansas.gov, and then you would click on the banner that says COVID-19 information, and under that, it's COVID-19 dashboard.
Okay.
And people can click on it and look at their individual counties to see what their vaccination rates are.
Okay. All right. Anything you want to share with the listeners? And I'll probably have you on if you're open to it, maybe over the next month as this thing plays out, because of all the conversation going on, or somebody from the department can come on and talk about it. Anything you want to share before I let you go? Because I know you got a busy schedule.
Yeah. So the vaccines are available to people at a lot of different locations around the state. And if they would like to get a vaccine and want to know the closest place, they can call 1-800-985-6030. And the vaccines are available to people at no cost to them.
Okay. I'm going to take 2 minutes, and then I'm going to let you go because I need to finish up with Pat. But I want to ask you about the vaccines, because there are those that believe that the vaccines are not safe. There was a lawsuit recently filed this past week based on some whistleblower information regarding the numbers of people that have been negatively affected by the vaccines. I can't remember if that was in Georgia or down there somewhere. Maybe you're aware of that, maybe you're not. The safety of the vaccine and the people that have had adverse effects here in Arkansas, let's just talk about Arkansas. Are you tracking the percentage of people that have had adverse effects created by the vaccine?
So we do follow the data that's in the vaccine adverse event reporting system. That reporting system does not tell you if the adverse event that someone reported was actually caused by the vaccine. The CDC investigates that. So I do not have the current percentage of people who had a vaccine adverse event in Arkansas caused by the vaccine. And the CDC tracks that over time, but I do not have that information personally.
Okay.
I think it's important to know that the vaccine studies were very well done, and they have been shown to be safe, and they work really well in protecting people and keeping them out of the hospital.
Okay. I'd like to ask you, if you would, let's have an offline conversation. I'll catch up with you or Matt this week. And I think one thing that would help people feel more comfortable about getting the vaccine is if they knew, as far as Arkansas population, that the number of people that have been adversely affected by getting the vaccine is little to none. If we could work on that, and maybe we'll come back on and talk about that. I think that would help some misinformation maybe that's being put out.
I think you are correct about that, and I will see what I can do to pull together some information that we can share that's easy to understand and not misunderstood like so much of the VAERS data are.
Okay. Dr. Dillaha, I appreciate you taking time out to be on the Kim Hammer Show. Look forward to having you back on, and we'll have further discussions. And again, that's Dr. Dillaha with the Arkansas Department of Health. And thank you for taking time to be on the Kim Hammer Show today. And I'll get that up on our website as far as the numbers that you gave me and the website so people can track it. All right?
Thank you.
All right.
Appreciate it.
Have a great day. All right, we're back, and I did want to take at least the final moments of the show to ask Pat about something. So, we're in the middle of the debate about the Arkansas teachers' health insurance costs, the state's health insurance costs. We've just dumped, I forgot what it was, $30 million, $40 million in to shore up the plan. Legislation was passed that took it away from EBD and put it in the State Board of Finance. We've hired consultants that have come in. They're looking at all the drivers to the cost of insurance. Let's just be radical for a minute. What could your approach, not you personally, because, I don't want anybody to think I'm directing business towards you, but the approach that you're talking about, if the model was changed to where we utilize the approach that you take and say we applied it to those large populations, A, possible, B, practical, C, achievable, and at the end of the day, would we look back 3 years from now and say, holy crap, those legislators really screwed up? Talk about that for a minute.
Wow. I mean, I'm not really sure how to address it. That's not really my wheelhouse, but what we do as a company with situations where we have government employees or we have massive numbers of employees for a company, for a large
company. Which you do have.
What we do is I know that the worst thing you can think about is I'm going to have a higher premium. That's not good for morale. Or I'm going to have more deductible that I've got to pay. Because those are the things that we've got to do, right? We're going to raise that premium up to keep the benefits where we want them to be. We're going to definitely, if we want to, lower the premiums or keep them where they're at, because those premiums go up 10, 15, 20, however many percent every year, and people just get tired of it. They've way outperformed any kind of increases in living and raises and any of that kind of stuff over the years. So the best scenario is to lower the premium or keep the premium where it is and get rid of the deductibles. So the people, I don't know the answer to get away from all of the abuse that goes on in the system. That's way bigger than me. I don't know. That's attorneys and whatever else stuff I've never even played on TV, right? But what I know for sure is you can take and you can put, we call it a deductible buster, and you can put a plan in place so the people are paying the same amount they are right now, and they go to use their insurance, and they're not going to have to pay a deductible out of their pocket. They're not going to have to pay co-pays before the insurance company pays. So our thing is we're not going to try and provide the base health plan. We're going to try and get people to governments, businesses, whatever, to get a different version of that health plan and have another plan that comes into place along the side of it to kind of create a hybrid plan from the standpoint of the employee. But as far as the employer, as far as the government, whatever, I don't know what the answer is to that, because they're going to do what they want to do to a level at least. But if you don't work with transparent pricing and work with what is true and fair pricing, I don't think there is any other answer. And so our private health plans don't come into play with a situation like that, because one of the ways we keep our rates down is we're very careful about who we insure. So we have people who have lots of health conditions or whatever, then we're probably going to do a private, a hybrid plan where we have some benefits of our plan and then we have maybe some kind of an ACA plan or whatever. And I do understand and recognize the need for that high risk situation, but too many people don't need that. And that's what keeps driving these costs out of sight. Is healthy people shouldn't have to be under the same heading or whatever, covering, if you would, as people who have some real health conditions. On the other side of that, people who have real health conditions have got to be covered. But part of the answer is to work through the shenanigans that goes on with unfair pricing for healthcare and unfair pricing for meds, especially meds. Because there's companies and organizations like, this is a good thing. If you don't have a high income and you have a med that's really expensive, you can go to prescriptionhope.com and you can get a med for like no more than $50, no matter what that cost is. So there's groups that are out there that do this. There are insurance companies that pay X and you pay only, whatever that might be that's remaining. So we know the numbers are way inflated on so much of this stuff. We call it the charge master rate. So if we can get rid of those kind of things, that's where we can start to take over our own health care. We can look for our own doctors, look for our surgeries. Almost 70% of stuff that you have done surgery-wise is shoppable. And healthcare in general, 70% is shoppable. You don't have to. You're not going to the emergency room and you're going to die in the hospital, right? And you're scared and what you're going to do. You can call around. You can do this. You can take it into control. But I had one of my clients, he's my client today because he went to his big name company and said, I need to get a CT scan. That's what my doctor told me. And they said, no, we're not going to pay for it. Since when does the insurance company trump the doctor? And that happens too much. I mentioned 2 books. The other was Marshall Allen's book, Never Pay the First Bill. An incredible, incredible book. And it's okay. I want to just one last time share how they can contact me and stuff like that. So I'm yourhealthplanman.com. And my number's 501-605-6935. And you can text your first and last name and the number 25 to me. And then you will be able to get a gift card to a restaurant here locally just by allowing me to give you a quote. There's a few restrictions, and we can go over some of those. But I'm telling you, this is a system that has to be, it's not broken. It's purposely not fixed. That's the bottom line to it.
I'll give you 30 seconds to answer this question. Pre-existing conditions. How do you deal with people that have pre-existing conditions? Because when you're covering 30,000 people, you got some people that have pre-existing conditions. 30 seconds.
Built into the plan, we have, if a person has pre-existing conditions and they have a private plan, that's one thing. But when you're talking about a big group plan or whatever, that is something that is all part of what we do. We might have waiting periods on certain things or whatever. But my thing would be not to try and bring our private plan into a big situation like that, but to marry it with a plan that will make those rates stay the same or even go down, raise the deductible on that plan to make it stay in line for their premiums, and then for us to step in to cover something that takes care of the deductible.
Okay.
That just makes perfect sense to me.
All right. We're going to have future conversations offline, but I'll get you back on the radio show and we'll talk more about it. All right. Today on the Kim Hammer Show, we had Dr. Dillaha from the Department of Health just kind of give us a snapshot of where we are, but also just had Pat Davis on. And Pat is with yourhealthplanman.com. I'll get that information up on the website. You've been listening to The Kim Hammer Show. You can go up to my site, www.thekimhammershow.com. Be kept up with some current events and follow along, and also message me if you have any questions. That's thekimhammershow.com. Thank you for listening to The Kim Hammer Show today on 101.1 FM The Answer. Have a great Saturday.